cardiac pathology. Uh, First, let me grade these different markers. Uh, the one like this yellow one, this is grade 1. This is not that much important. Then the second one is this marker, this one. This one is grade 2, right? Little bit important than the yellow one. Then we have grade 3. This is important, right? Uh, this green one. Then fourth one, we have this orange type, this one. This is grade 4. This is more important than third one. And the final one, which we shouldn't forget about that, and that one is this one, right? So this is grade 5. Okay, so let us continue. Congenital heart diseases, right to left shunts, early cyanosis, blue babies, diagnosed prenatally or become evident immediately after birth, require urgent surgical treatment and or maintenance of patent ductus arteriosus. The 5 T's: Truncus Arteriosis, 1 vessel, transposition of great vessels, 2 switched vessels, 3rd tricuspid atresia, tetralogy of Fallot, 4 tetra, TAPVR, 5 liters, 5 liters in the name. Let's see again. Right to left shunts, early cyanosis, blue babies, diagnosed prenatally, evident immediately after birth, require urgent surgical treatment and or maintenance of a PDA. The 5 T's: Truncus arteriosis, 1 vessel, transposition of great vessels, 2 switched vessels, tricuspid atresia, 3 tetralogy of Fallot, tetra, TAPVR, 5 liters in the name. Persistent truncus arteriosis. Truncus arteriosis fails to divide into pulmonary trunk and aorta due to failure of aortic pulmonary septum formation. Most patients have accompanying VSD, ventricular septal defect. Persistent truncus arteriosis. Truncus arteriosis fails to divide into pulmonary trunk and aorta. Failure of aorticopulmonary septum formation. Most patients have accompanying VSD. D. Transposition of great arteries. Aorta leaves right ventricle, that would be interior, and pulmonary trunk leaves left ventricle, that would be posterior. Separation of systemic and pulmonary circulations, not compatible with life unless a shunt is present to allow mixing of blood. For example, VST, PDA, or patent foramen ovale. Due to failure of the aorticopulmonary septum to spiral, narrow superior mediastinum causes egg on a string appearance on chest X-ray. This is more important than all these 5 grades, or we use this for comparing. Okay, without surgical intervention, most infants within the first few months of life. Once again, aorta leaves right ventricle, that would be interior. Pulmonary trunk leaves ventricle, that would be posterior. Separation of systemic and pulmonary circulations, not compatible with life unless a shunt is present to allow mixing of blood, VSD, PDA, or patent foramen ovale. Due to failure of the aorticopulmonary septum to spiral, narrow superior mediastinum causes egg on a string appearance on X-ray. Without surgical intervention, most infants die within the first few months of life. Right? So we have aorta, right? that would come from right ventricle. Then we have pulmonary artery that would come from left ventricle. Right? Okay. Then we have tricuspid atresia, absence of tricuspid wall, hypoplastic right ventricle, requires both ASD and VSD or PDA for viability. ECG shows hypertrophy of right atria, tall P waves, and left ventricle, that is left axis deviation. Tricuspid atresia, absence of tricuspid wall, hypoplastic right ventricle, requires both ASD and VSD for viability. ECG shows hypertrophy of right atria, tau P waves, and left ventricle, left axis deviation. Tetralogy of Fallot, caused by anterosuperior displacement of the infundibular septum. Most common cause of early childhood cyanosis. Pulmonary infundibular stenosis, most important determinant for prognosis. Right ventricular hypertrophy, boot-shaped hurt on chest X-ray. Overriding aorta, straddles VSD receiving blood from both left ventricle and right ventricle. VSD, pulmonary stenosis, forces right to left flow across VSD. Right ventricular hypertrophy, tit spells, often caused by crying, fever, and exercise due to exacerbation of right ventricle outflow obstruction. Okay, prove, that is squatting. Squatting E. Okay, increase systemic vascular resistance, decrease right to left shunt, improves cyanosis. Associated with 22q11 syndromes. Once again, tetralogy of Fallot, caused by anterosuperior displacement of the infundibular septum, most common cause of early childhood cyanosis. Pulmonary infundibular stenosis, most important determinant for prognosis. Right ventricular hypertrophy, boot-shaped hurt on chest X-ray. Overriding aorta, straddles VSD receiving blood from both left ventricle and right ventricle. VSD, pulmonary stenosis, forces right to left flow across VSD. Right ventricular hypertrophy, TAT spells, often caused by crying, fever, exercise due to exacerbation of right ventricular outflow obstruction. PRO, PEEP for pulmonary infundibular stenosis, R for right ventricular hypertrophy, O for overriding aorta, V for VSD. Squatting, increase systemic vascular resistance, decrease right to left shunt, improve cyanosis associated with 22q11 syndromes. Now, TAPVR, total anomalous pulmonary venous return. Pulmonary veins drain into right heart circulation. Superior vena cava, coronary sinus, etc. Associated with ASD and sometimes PDA to allow for right to left shunting to maintain cardiac output. Once again, pulmonary veins drain into right heart circulation. Superior vena cava, coronary sinus, etc. Associated with ASD and sometimes PDA to allow for right to left shunting to maintain cardiac output. Epstein anomaly, displacement of tricuspid wall leaflets downward into right ventricle, atrializing the ventricle. Tricuspid regurgitation, accessory conduction pathways, right-sided heart failure. Rare, can be caused by lithium exposure in utero. Once again, Epstein anomaly. Displacement of tricuspid wall leaflets downward into right ventricle, atrializing the ventricle. Tricuspid regurgitation. Accessory conduction pathways. Right-sided heart failure. Rare, can be caused by lithium exposure in utero. Now left to right shunts. Acyanotic at presentation. Cyanosis may occur years later. Frequency VSD greater than ASD greater than PDA. Right to left shunts. Early cyanosis. Left to right shunts. Later cyanosis. Once again, left to right shunts. Acyanotic at presentation. Cyanosis may occur years later. Frequency VSD greater than ASD than PDA. Right to left shunts, early cyanosis. Left to right shunt, later cyanosis. VSD, asymptomatic at birth, manifests weeks later or remain asymptomatic throughout life. Most smaller defects self-resolve. Larger defects, if left surgically untreated, causes increased pulmonary blood flow and left ventricular overload, may progress to heart failure. Oxygen saturation increase in right ventricle and pulmonary artery. Once again, asymptomatic at birth, manifest weeks later, or remain asymptomatic throughout life. Most smaller defects self-resolve. Larger defects, if left surgically untreated, increases pulmonary blood flow and left ventricle overload, may progress to heart failure. Oxygen saturation increase in right ventricle and pulmonary artery. Then we have ASD, defect in interatrial septum, systolic ejection murmur, wide fixed split S2. Ostium secundum, defects most common, usually isolated finding. Ostium primum, defects rarer, with other cardiac anomalies. Symptoms range from none to heart failure, distinct from patent foramen ovale, which is due to failed fusion. Oxygen saturation increase in right atria, right ventricle, and pulmonary artery may lead to paradoxical emboli. Systemic venous emboli use ASD to bypass lungs and become systemic arterial emboli associated with Down syndrome. Once again, defect in interatrial septum, systolic ejection murmur, wide fixed split S2, ostium secundum defects most common, usually isolated finding, ostium primum defects rarer, with other cardiac anomalies. Symptoms range from none to heart failure, distinct from patent foramen ovale, which is due to failed fusion. Oxygen saturation increase in right atria, right ventricle, and pulmonary artery may lead to paradoxical emboli. Systemic venous emboli use ASD to bypass lungs and become systemic arterial emboli associated with Down syndrome. PDA, in fetal period, shunt is right to left, which is normal. In neonatal period, decrease pulmonary vascular resistance, so shunt becomes left to right. Progressive right ventricular hypertrophy and or left ventricular hypertrophy and heart failure. Continuous machine-like murmur. Patency is maintained by prostaglandin E synthesis and low oxygen tension. Uncorrected PDA can eventually result in late cyanosis in the lower extremities. differential cyanosis. PDA is normal in utero and normally closes soon after birth. Once again, PDA in fetal period, shunt is right to left, which is normal. In neonatal period, decreased pulmonary vascular resistance. So, shunt becomes left to right. Progressive right ventricular hypertrophy and left ventricular hypertrophy and heart failure. Continuous machine-like murmur. Patency maintained by prostaglandin E synthesis and low oxygen tension. Uncorrected PDA can eventually result in late cyanosis in the lower extremities and differential cyanosis. PDA is normal in utero and normally closes soon after birth. Eisenmenger syndrome. Uncorrected left to right shunt VSD, ASD, or PDA. Increased pulmonary blood flow. Pathologic remodeling of vasculature. Pulmonary arterial hypertension. Right ventricular hypertrophy occurs to compensate. Shunt becomes right to left when right ventricle pressure is greater than left ventricular pressure. Causes late cyanosis, clubbing, and polycythemia. This is important. Late cyanosis, clubbing, and polycythemia. Age of onset varies depending on size and severity of initial left to right shunt. Once again, Eisenmenger syndrome, uncorrected left to right shunt, VSD, ASD, PDA. Increased pulmonary blood flow, pathologic remodeling of vasculature, pulmonary arterial hypertension. Right ventricular hypertrophy occurs to compensate. Shunt becomes right to left when right ventricular pressure becomes greater than left ventricular pressure. Causes late cyanosis, clubbing, and polycythemia. Age of onset varies depending on size and severity of initial left to right shunt. So, in starting, it would be left to right by this red one, right? Then it would become right to left. Coarcatation of aorta. Aortic narrowing near insertion of the ductus arteriosus. Juxtaductal associated with bicuspid aortic wall. Other heart defects and Turner syndrome. Hypertension in upper extremities. Lower extremities are cold with weak delayed pulses. Brachiofemoral delay. With each intercostal arteries enlarged due to collateral circulation. Complications include heart failure, increased risk of cerebral hemorrhage, that is, Berry aneurysms, aortic rupture, and possibly possible infective endocarditis. Again, aortic narrowing near insertion of the ductus arteriosus, juxtaductal, associated with bicuspid aortic wall, other heart defects, and Turner syndrome. Hypertension in upper extremities. Lower extremities are cold with weak, delayed pulses, brachiofemoral delay, with each intercostal arteries enlarged due to collateral circulation. Complications include heart failure, increased risk of cerebral hemorrhage, Berry aneurysms, aortic rupture, and possible infective endocarditis. Persistent pulmonary hypertension of the newborn. Persistence of increased pulmonary vascular resistance after birth associated with abnormal development and postpartum adaptation of pulmonary vasculature. Risk factors include aspiration of meconium, stained amniotic fluid, and neonatal pneumonia. Lead to right to left shunt through foramen well in ductus arteriosus. Newborn presents with signs of respiratory distress, tachypnea, and cyanosis. Preductal oxygen saturation is often higher than postductal. Equal pulses, no delay. Once again, persistent pulmonary hypertension of the newborn. Persistence of the increased pulmonary vascular resistance after birth associated with abnormal development and postpartum adaptation of pulmonary vasculature. Risk factors include aspiration of meconium-stained amniotic fluid and neonatal pneumonia. Lead to right to left shunt through foramen oval in ductus arteriosus. Newborn presents with signs of respiratory distress, for example, tachypnea and cyanosis. Preductal oxygen saturation is often higher than postductal. Equal pulses, no delay. Congenital cardiac defect associations. Prenatal alcohol exposure, that is also called fetal alcohol syndrome. The defect would be VSD, ASD, PDA, tetralogy of Fallot. Congenital rubella, PDA, pulmonary artery stenosis, septal defects like VSD, ASD, PDA. Down syndrome associated with atrioventricular septal defect, endocardial cushion defect, VSD and ASD. Infant of patient with diabetes during pregnancy. Transposition of great arteries. Truncus Arteriosis, Tricuspid atresia, and VSD. Marfan syndrome associated with mitral valve prolapse, thoracic aortic aneurysm, dissection, aortic regurgitation, prenatal lithium exposure, Epstein anomaly, Turner syndrome, bicuspid aortic wall coarcatation of aorta, Williams syndrome, supravalvular aortic stenosis, 22q11 syndromes, Truncus arteriosus, tetralogy of Fallot. Once again, prenatal alcohol exposure, fetal alcohol syndrome, VSD, ASD, PDA, tetralogy of Fallot, congenital rubella, PDA, pulmonary artery stenosis, septal defects, Down syndrome, AV septal defect, endocardial cushion defect, VSD, ASD, infant of patient with diabetes during pregnancy, transposition of great arteries, truncus arteriosis, tricuspid atresia, VSD, Marfan syndrome, mitral valve prolapse, this is important, thoracic aortic aneurysm and dissection, aortic regurgitation, prenatal lithium exposure, Epstein anomaly, Turner syndrome, bicuspid aortic wall coarctation of aorta, Williams syndrome, supravalvular aortic stenosis, 22q11 syndromes, Truncus arteriosus, tetralogy of Fallot, hypertension, persistent systolic BP greater or equal to 130 millimeter of mercury and or diastolic BP greater or equal to 80 millimeter of mercury. Risk factors: increased age, obesity, diabetes, physical inactivity, high sodium diet, excess alcohol intake, tobacco smoking, family history, incidence, greatest in black, then white, then Asian populations. Features: 90% of hypertension is primary, that is essential, related to increase in cardiac output and increase in total peripheral resistance. Remaining 10% mostly secondary to renal or vascular diseases such as fibromuscular dysplasia, characteristic strength of beads, appearance of renal artery, usually seen in adult females, atherosclerotic renal artery stenosis, primary hyperaldosteronism or obstructive sleep apnea, hypertensive urgency, severe, greater or equal to 180 by greater or equal 120 mm of Hg. Okay, hypertension without acute end organ damage. Then we have hypertensive emergency.
That was formerly called malignant hypertension. Severe hypertension with evidence of acute end organ damage, for example, encephalopathy, stroke, retinal hemorrhages, exudates, papilledema, MI, heart failure, aortic dissection, kidney injury, microangiopathic hemolytic anemia, eclampsia. Arterioles may show fibrinoid necrosis, predisposed to coronary artery disease, left ventricular hypertrophy, heart failure. AFib, aortic dissection, aortic aneurysm, stroke, chronic kidney disease, CKD, hypertensive nephropathy, retinopathy. Once again, hypertension, persistent systolic BP greater or equal to 130 mm of mercury, and our diastolic BP greater or equal of 80 mm of mercury. Risk factors increase age, obesity, diabetes, physical inactivity, high sodium diet, excess alcohol intake, tobacco smoking, family history, incidence, greatest in black, then white, then Asian populations. Features 90% of hypertension is primary, essential, related to increase in cardiac output and total peripheral resistance. 10% mostly secondary to renal or renovascular diseases such as fibromuscular dysplasia, characteristic string of beads, appearance of renal artery, adult females, atherosclerotic renal artery stenosis, primary hyperaldosteronism or obstructive sleep apnea, hypertensive urgency, severe greater or equal to 180 by greater or equal to 120 mm of mercury, hypertension with acute without acute end organ damage. That is urgency. Then hypertensive emergency. That was formerly called malignant hypertension. Severe hypertension with evidence of acute end organ damage. For example, encephalopathy, stroke, retinal hemorrhages, exudates, papilledema, MI, heart failure, aortic dissection, kidney injury, microangiopathic hemolytic anemia, eclampsia, arterioles that would show fibrinoid necrosis in case of hypertensive emergency, predisposed to coronary artery disease, left ventricular hypertrophy, heart failure, atrial fibrillation, aortic dissection, aortic aneurysms, stroke, coronary kidney disease, hypertensive nephropathy, retinopathy. Hyperlipidemia signs, xanthomas, plaques are nodules composed of lipid-laden histiocytes in skin, especially the eyelids, that is called xanthelasma. Once again, xanthomas. Plaques are nodules composed of lipid-laden histiocytes in skin, especially in the eyelids, that is called xanthelasma. Tendinous xanthoma, lipid deposit in tendon, especially Achilles tendon, and finger extensors, associated with familial hypercholesterolemia. Corneal arcus, lipid deposit in cornea, common in adults, common in older adults. Arcus senalis, but appears earlier in life with hypercholesterolemia. Once again, hypercholesterolemia signs are xanthomas, tendinous xanthoma, corneal arcus. What are xanthomas? Plaques are nodules composed of lipid-laden histiocytes in skin, especially the eyelids, that is xanthelasma. Tendinous xanthoma, lipid deposit in tendon, especially Achilles tendon, finger extensors associated with familial hypercholesterolemia. Corneal arcus, lipid deposit in cornea, common in older adults. Arcus senalis, but appears earlier in life with hypercholesterolemia. Okay, now atherosclerosis, very common form of arteriosclerosis, which is the hardening of arteries. Disease of elastic arteries and large arteries and the medium-sized muscular arteries caused by build-up of cholesterol plaques in tunica intima. Location: abdominal aorta greater than coronary artery, then popliteal artery, then carotid artery, then circle of Wallis. A copycat named Wallis. A. Abdominal aorta. CO. Coronary artery. P. Popliteal artery. Cat. Cat, that is carotid artery. Named Wallis, that is circle of Wallis. Risk factors: modifiable hypertension, tobacco smoking, dyslipidemia, increased LDL, decreased HDL, diabetes. Non-modifiable: age, male sex, postmenopausal status, family history. Symptoms: angina, claudication, but can be asymptomatic. Progression: inflammation important in pathogenesis, endothelial cell dysfunction, macrophage and alveolar accumulation, that is an MCQ. Form cell formation, various trees that will be formed. Smooth muscle cell migration involves PDGF, plasma derived growth factor, and fibroblast growth factor. Proliferation and extracellular matrix deposition. That could be platelet derived growth factor. Okay. So proliferation and extracellular matrix deposition, fibrous plaque, complex atheromas, calcification, calcium content correlates with the risk of complications. Complications: ischemia, infarction, aneurysm formation, peripheral vascular disease, thrombosis, embolism. So we have endothelium, then we have lumen, then we have smooth muscle. So then monocyte and with damaged endothelium, right? Then we have LDL laden macrophages that are cholesterol, right? Fatty streak will be formed with form cell, smooth muscle, migration would be there, fibrous plaque formation would be there, smooth muscle, right? Okay. Once again, atherosclerosis, very common form of arteriosclerosis, which is the hardening of arteries. Disease of elastic arteries, large and medium-sized muscular arteries caused by build-up of cholesterol plaques in tunica intima. Intima is important. Abdominal aorta, which is on the top. Then coronary artery, then popliteal artery, then carotid, then circle of Wallis. A copycat named Wallis. Risk factors: modifiable hypertension, tobacco smoking, dyslipidemia, that is increased LDL, decreased HDL, diabetes. Non-modifiable: age, male, sex, postmenopausal status, family history. In symptoms: angina, claudication, but can be asymptomatic. Progression: inflammation important in pathogenesis. There would be endothelial cell dysfunction, so macrophage and LDL accumulation that will lead to form cell formation, fatty streaks, and smooth muscle cell migration, which would involve platelet derived growth factor and fibroblast growth factor. This is platelet derived growth factor. Okay. Proliferation and extracellular matrix deposition, fibrous plaque, complex atheromas formation, which is at later stage. Calcification, calcium content correlates with the risk of complications. This is important. Complications would be ischemia, infarction, aneurysm formation, peripheral vascular disease, thrombosis, and embolism. So then we have cholesterol emboli syndrome, microembolization of cholesterol displaced from atherosclerotic plaques in large arteries, usually the aorta, results in end organ damage due to small artery emboli
and an inflammatory response. For example, livedo reticularis, digital ischemia, that is blue toe syndrome, acute renal failure, cerebrovascular accident, gut ischemia. Pulses remain palpable because larger arteries are unaffected. May follow invasive vascular procedures, angiography, angioplasty, and endovascular grafting. Arteriosclerosis, common form of this is arteriolosclerosis, which is the common form of arteriosclerosis. Affects small arteries and arterioles. Two types, hyaline and hyperplastic. Hyaline, vessel wall thickening, secondary to plasma protein leak into subendothelium. Hypertension or diabetes mellitus. Hyperplastic, that is onion skinning, in severe hypertension with proliferation of smooth muscle cells. Okay, you can see this in A and B. Okay, then aortic aneurysm, localized pathologic dilation of the aorta. Abdominal and or back pain, sign of leaking, dissection or imminent rupture. Thoracic aortic aneurysm, associated with cystic medial degeneration. Risk factors include hypertension, bicuspid aortic valve, connective tissue disease, for example, Marfan syndrome, also associated with tertiary syphilis, that is obliterative enteritis of the vasa vasorum. Aortic root dilation may lead to aortic valve regurgitation. Then we have abdominal aortic aneurysm associated with transmural, that is all three layers inflammation, and extracellular matrix degradation. Risk factors include tobacco smoking, which is the strongest risk factor for abdominal aortic aneurysm. Increased age, male sex, family history may present as palpable pulsatile abdominal mass, that is arrows in A point to outer dilated aortic wall. Okay, so rupture may present as striate of pulsatile abdominal mass, acute abdominal or back pain, and resistant hypertension. Most often, infrarenal distribution of vasa vasorum is reduced. Okay, so once again, cholesterol emboli syndrome, microembolization of cholesterol displaced from atherosclerotic plaques in large arteries, usually the aorta, results in organ damage due to small artery emboli, inflammatory response, for example, livedo reticularis, digital ischemia, blue toe syndrome, acute renal failure, cerebrovascular accident, gut ischemia. Pulses remain palpable because larger arteries are unaffected. May follow invasive vascular procedures, for example, angiography, angioplasty, and endovascular grafting. Arteriolosclerosis, common form of arteriosclerosis, affects small arteries and arterioles. Two types, hyaline, hyperplastic. Hyaline, vessel wall thickening secondary to plasma protein leak into subendothelium. In hypertension or diabetes mellitus. Hyperplastic, onion skinning in severe hypertension with proliferation of smooth muscle cells. Aortic aneurysm, localized pathologic dilation of the aorta, abdominal and or back pain, sign of leaking, dissection or imminent rupture. Then we have thoracic aortic aneurysm associated with cystic medial degeneration. Risk factors include hypertension, bicuspid aortic valve, connective tissue disease, Marfan syndrome, also associated with tertiary syphilis, that is obliterative enteritis of vasa vasorum. Aortic root dilation may lead to aortic valve regurgitation. Okay, then we have abdominal aortic aneurysm associated with transmural, that is all three layers, inflammation and extracellular matrix degradation. Risk factors include tobacco smoking, strongest risk factor, increased age, male sex, female history, palpable pulsatile abdominal mass. Rupture, triad of pulsatile abdominal mass, acute abdominal or back pain with infrarenal distribution of vasa vasorum is reduced. Traumatic aortic rupture due to trauma and or deceleration injury, most commonly at aortic isthmus, proximal descending aorta just distal to origin of left subclavian artery. X-ray would show widened mediastinum. Aortic dissection, longitudinal intimal tear forming a false lumen. Hypertension is the strongest risk factor. Then we have bicuspid aortic wall, inherited connective tissue disorders, for example, Marfan syndrome, can present sudden onset chest pain relating to back, plus minus markedly unequal BP in arms. Chest X-ray can show mediastinal widening, organ ischemia, aortic rupture, death. Then we have Stanford type A proximal, involves ascending aorta, that is red arrow in A. Okay, may extend to aortic arch or descending aorta, blue arrow in A. Okay, may result in acute aortic regurgitation or cardiac tamponade. Treatment is surgery. Stanford type B, which is distal, involves only descending aorta, below left subclavian artery. Treatment is beta blockers, then vasodilators. Okay, then we have subclavian steal syndrome. Stenosis of the subclavian artery proximal to origin of vertebral artery. Okay, proximal to the origin of vertebral artery. Hypoperfusion distal to stenosis. Reverse blood flow in ipsilateral vertebral artery. Reduced cerebral perfusion on exertion of affected arm. Causes arm ischemia, pain, paresthesia, vertebrobasilar insufficiency, dizziness, and vertigo. Increase are greater than 15 mm of mercury difference in systolic BP between arms, associated with atherosclerosis, Takayasu arteritis, and heart surgery. Once again, traumatic aortic rupture due to trauma and or deceleration injury, most commonly it aortic isthmus, proximal descending aorta just distal to origin of the left subclavian artery. X-ray would show widened mediastinum, aortic dissection, longitudinal intimal tear forming a false lumen, associated with hypertension, which is the strongest risk factor. Bicuspid aortic wall, inherited connective tissue disorders, for example, Marfan syndrome, can present with tearing, sudden onset chest pain relating to the back, plus minus markedly unequal BP in arms. Chest X-ray mediastinal widening can result in organ ischemia, aortic rupture, death. Stanford type A, that is proximal, involves ascending aorta, red arrow in A. Okay, may extend to aortic arch or descending aorta, blue arrow in A. May result in acute aortic regurgitation or cardiac tamponade. Treatment surgery. Stanford type B, distal, involves only descending aorta, below left subclavian artery. Treatment is beta blockers, then vasodilators. So we have Stanford classification type A, that is type 1, and type 2, that is DeBakey classification. Type 1 and type 2 he classified. And we have type B. In type A we have ascending, in type A we have ascending, in type B then we have descending. Okay. Subclavian steal syndrome, stenosis of the subclavian artery proximal to origin of vertebral artery. Hypoperfusion distal to stenosis. Reversed blood flow in ipsilateral vertebral artery. Reduced cerebral perfusion on exertion of affected arm. Causes arm ischemia, pain, paresthesia, vertebrobasilar insufficiency, dizziness, or type greater than 15 mm of Hg difference in systolic BP arms. between arms associated with atherosclerosis, Truncus arteritis, and heart surgery. Right. So then we will continue further.